The title of this talk is Psychology and Human Factors in Airway Management. And I have to tell you, this wasn't something that came up spontaneously to me. Back in the summer, I was invited to teach an advanced airway course with a couple people, Levitan and Weingart, and a guy by the name of Ken Butler from Baltimore. And so I was assigned 3 talks, and one of them was a psychology talk. I said, how am I going to fill 40 minutes with this? And it was fascinating preparing for this. And at the end of this talk, we sat down with a group of 40 people that were attending this, and the conversation went on. And really what you're going to see now is not a recycled talk, but how that talk has sort of evolved to, I think, what's a new passion for me. Anyway, so the plan, this talk, it's a lot of Brownian motion. I'm going to be all over the place. The theme is going to be airway management. I'm going to talk about human factors. Peppered throughout this, I'm going to talk about biases that affect our decision-making in airway management. I'm going to talk about things that we don't usually discuss, which is how we manage stress in taking care of sick patients and how we can take control. So airway management, it seems pretty straightforward. It's what you've trained for. Nothing could possibly go wrong unless you're ice fishing and something bad happens. All right. So I'm going to use a couple cases. So you walk into your resuscitation room, and this is what's on the wall. There's 2 cases that I'm going to discuss, a 38-year-old self-inflicted gunshot wound and a post-hanging patient. First one I'm going to talk about is the post-hanging. So you got a 5-minute warning. There's a 55-year-old post-hanging, morbidly obese, and they're not tubed, right? So that's the situation. In emergency medicine, we have television shows about us. We should own the airway. Back in our day, it was a big fight between anesthesia and us. Should we be doing rapid sequence intubation, pushing these drugs? It's conflict. No. Now it's clear. We do own the airway. But I'm going to ask you, so you know this case, okay? It's 5 minutes. It's a hanging. And what's the most important airway tool? So you walk into your resuscitation room. What's the most important airway tool that you can use? Here. You got one thing to pick up. Residents are over here, scattered here. Come on. One thing. Okay. Yeah, good. So your focus is going to be to oxygenate them. I'm going to suggest that it's probably this, okay? This is an iPhone 6. I've got a 6 Plus, so does Scott. You can work up to the big phone. But we don't appreciate the fact that, yes, we own the airway, but is it appropriate for us always to own the airway? I'm quite comfortable in managing most things that are going to be out there, but it doesn't necessarily mean I'm going to put on my cowboy boots and jump in and take every airway that comes in. We have to manage the balance between keep calm and own the airway and getting help. And one of the things that gets in our way is our egos, right? That we've taken such a long time to fight for ownership for the airway that now we're not going to ask for help. And asking for help is a sign of weakness. And we do have to remember that our goal is not to prove that we got the tube. Our goal is to make sure that we have good patient care. And sometimes that's involved me calling a friend, an anesthetist. 90% of the time, 95% of the time, perhaps 98% of the time, we are going to own the airway, but we have to remember that we have to call for help. These are the 4 C's that is probably the main theme of this talk that I think we need to be successful, whether it's being a parent, whether it's managing an airway, or it's managing any resuscitation area. They're competence, context, confidence, and conscientiousness. Most of what we do is focused from a residency point of view is on the issue of competence, is being good at what we do. But if you're competent, only competent, and you don't appreciate context, the environment, so you can be really good at doing an airway, and somebody doesn't need an airway, and you're putting them at risk. Or you can be really good at doing an amputation, but if it's done for the wrong reasons, the patient's not going to do well. Confidence. We all know people that walk in, they own the resuscitation room, but they're not particularly confident, right? They're not particularly competent. And this last one is conscientiousness, and I'll get back to that in a minute because I think it's the most important thing. So when you walk by a room, you're coming on shift, and you see this patient, right? What are you thinking? I know a lay person's going to go, ooh, right? You're going to say, as an emergency medicine resident, what are you going to say? Nice tube, right? Wow, that was a success. The bad patient, that was a success. But what we don't know is what happened along the way. What happened during that resuscitation, trying to acquire that tube. And we need to redefine success. This is from a study done in San Diego, I believe. Davis had about 500 publications as a result of this study. But essentially, paramedics were doing rapid sequence intubation on head-injured patients. And they monitored everything that happened, including their saturations and their end tidal. And so this is patient X. Saturations in this head-injured patient started at 100%. They did rapid sequence intubation. During period A, which is the intubation, SATs dropped to under 80%. They had positive end tidal, and then this is what probably was adrenaline-induced hyperventilation from they got the tube and they're squeezing the bag too hard. And so when you ask the medics how this went, they said head injured patient, did a rapid sequence intubation, got the tube on first attempt, successful airway. And that's what we'd all say. But if you go back and look at this, we know from these two events we'd have at least probably doubled this patient's mortality. So we need to, again, redefine success about not what the end outcome is, but what happens during the process. Malcolm Gladwell in the book Outliers has a chapter called 10,000 hours. And 10,000 hours is the amount of time he feels it requires to be expert at whatever you do. What do you think 10,000 hours works out to be if you're working 40 hours a week? It's about 10 years. Some people do it in less, some people do it in more. But this is to be at the top of your game. This is for the Wayne Gretzky's of the world, the concert violinist or whatever. That's what is a mean number that he gives all kinds of examples for. Macklemore said it in his song in a different but similar way. The greats weren't great because at birth they could paint. The greats were great because they painted a lot. And saying the exact same thing that Macklemore did. So practice. How many tubes? What's interesting is athletes at the top of their game, violinists, whoever this guy is, and fighter pilots spend probably 95 to 98% of their time practicing, and about 2% of their time performing. Where in medicine, we do the opposite. You go out and do clinical care 95% of the time, and you have your education days or whatever, and we practice only about 5 to 10% of the time. So let's do some math here for a sec. And I'm not good at math. We own the Airway, and appropriately so, and I'm not saying otherwise. But this is our place. 75,000 patient visits, 500 tubes a year, roughly. There's 9 shifts a day. Average full-time guy does about 15 shifts a month. That means in our area that of those 15, only 2 to 3 might be in the resuscitation area. How many tubes do you think that you're going to be potentially exposed to over that period? Per month? 1 to 3. 1 to 3 tubes. And then who's in line to do those tubes? Senior resident, junior resident, paramedic, respiratory therapist, janitor, everybody wants to get that tube. So as a staff person, even though we own the Airway, how many opportunities do we get our hands on? And is that important? We've passed our exams, we do our, MoComp or whatever, and we're good. But how important is that? It gets back to how we practice. It's interesting. When we practice, I'll bet you in this room, you've practiced on 2 faces. Okay, I'm not talking about clinical patients. You practice on a Laerdal and maybe a Medi. Right? And you do it over and over again. You've done maybe somebody else, a TrueCore or some other manikin. But say 5 faces. You've practiced airway management. There are over 7 billion people in the world. Right? There's over 7 billion airways. And you've all had the experience that they're not all the same. And you know what? There's no one manikin out there. There's not one manikin that promotes all of the basic life-saving core skills of doing a jaw thrust, of doing external laryngeal manipulation, effective BABM where you see chest rise, that fosters what I call best look direct laryngoscopy with head lift and that kind of thing, accommodates various supraglottic devices, and gives a realistic surgical airway. Despite all the technology we have, there's no manikin that really does that in one body. And the issue is, so what's our skill transfer when we take these learn from these mannequins and say we have to practice or perform on real patients. And one of the reasons why I think video laryngoscopy has become so prevalent is that when you compare direct laryngoscopy on a mannequin, a Laerdal mannequin, it's a lot harder than it is doing video, right? So it promotes that skill. People say, well, why would I do this if I can do this? When actually, if you practice on human tissue, it is pretty damn easy to do good direct laryngoscopy and be successful. This is one of our clinical grade cadavers. I'm director of this program, and we use this. Our residents have access all the time. And I'm going to tell you, this is the most important move, and you don't realize this until you play with these, is the head lift. If I had one move that's going to improve my view, and you're going to see it, this is one of our senior residents who's doing an airway fellowship, all he's doing is head lift. This is the cadaver tissue. And with that head lift, that's what changes the view. No mannequin promotes that, so people say, oh yeah, I'm supposed to do it, but I'm not going to do it because it doesn't do anything. You do this on human tissue, and it's remarkable. A lot of times we can't do it because they're in C-spine precautions, which in my mind doesn't matter anyway. If I need to lift and do a head lift, I'm going to do a head lift to manage that airway. So what's happening, unfortunately, is we're having skill erosion, right? We're losing our core skills because plastic doesn't promote it, and we don't get to practice with tissue. Okay, case. You get a call from outlying hospital, alcoholic, their level is 75. They have sleep apnea, got a cut on their head. They need to send to your institution for a CT. They don't know whether they're drunk or whether they got a head injury. The patient's 350 pounds, SATs are 100%, and on the GCS Likert scale, it's 8, okay? And so this is the issue of context. I know there's many people that recognize this environment. I used to go to Dryden on a regular basis. Here's Dryden. This isn't a picture of the resuscitation room, but it's not far off. Right? That's what it'll look like. And so that's the context there, that this is there's a sending person. My context is this. Our department is as long as a football field, and when we have a trauma, everybody but dermatology is there. It's hard you have to actually reserve space. And so that's a big, difference in the environment. And so we get on the phone. We have to say, what skills do I have, and what skills do they have when we're trying to take care of that patient? And what's the greatest risk? Is it the condition, or is it the caregiver? We could say, well, you're an emergency physician. Clearly, you should be sending this patient, but they should have their airway management. Is that in the best interest of the patient? And this is a pet peeve of mine, is that they call us for help, and we say, just ABCs, manage their ABCs, just manage their airway, right? And I can tell you about a case, a small town, I'm on for our flight, and it's a 17-year-old kid, motorcycle crash, head injury, and they called for life flight, and so I called, and the nurse picks up the phone and says, well, the doctor's on the phone talking to neurosurgery, and all I hear in the background is, head injury, they're calling for us, a groaning patient. I have a mental picture of what that person is. I know who she's talking to, okay? She's talking, this is July, she's talking to a PGY2 in neurosurgery, who's now a neurosurgeon talking to a doc, right? And saying, I took HELS, managed the airway, and carry on with things. So what I said to the nurse, I said, I want you to hang up the phone. He said, I can't, she's talking to neurosurgery. I said, no, I know. I want you to hang up the phone. And says, no, I can't. And so I convinced her. She hung up the phone. The doc yells at the nurse and passes me the phone. I said, listen, I want you to turn around and describe the patient. The patient was, GCS or 5 or something, but SATs were 100%, right? We're about a 40-minute flight from her. What should I do? Should I recommend managing the airway or saying wait? We have to put our head in their head before we give advice. So intubate before transfer. The content would say yes, head injured, GCS 8, alcoholic, and a fairly long transport time. So get on with that. The context is this. It's a small hospital. The last time this person intubated was 5 years ago. The patient's 350 pounds. They're satting 100%, and they've never done an RSI. What's in the best interest of the patient? Put oxygen on them, just make sure if things crash, call me back. Again, the goal of airway management, our outcome goal isn't to see a piece of plastic there. Our outcome, our goal is to try to prevent and promote oxygenation by any means, bag mask, supraglottic device, or an endotracheal tube. So we can't generalize. Another bias, we can't, this is the generalizability bias. Is the evidence or experience generalizable to a different context? And there's all kinds of studies that come out that, there's a device out there and it has a 98% success rate. It's really cool. You use it in a manikin, it must be wonderful. But again, it's wonderful and it's a 98% success rate because the people using it got really good at it. Right? It doesn't mean that that skill is going to be transferable to you in this situation. So the next C is confidence. So what's the number needed to be confident? And we all know this is the scariest person, right? The scariest person is the person who doesn't know, not knowing what you don't know, right? They think they know it and they don't. They're not going to listen to anything. We all know this skilled clinician. He's now an ENT surgeon. So what's the quote that, anybody remember a quote from him? Well, so this is one of them. We all got plans till you got punched in the mouth, right? And people laugh and they relate to it because we've all been punched in the mouth. And it's an important thing to do. This was a study that was done and when they were about 30 years ago, and they were trying to figure out what's the number of tubes that medics need to become good at intubation. So one group did 5, one group did 10, and one group did 20. When they asked them who felt most confident about their airway skills, it was the group that did 5. And why is that, right? Well, the reason why is that they didn't have these, big black holes with white pearlies on either side. They've experienced throughout this situation where they don't see what they're supposed to see. They get humbled by that. And that's the challenges when we don't have a lot of experiences. We don't have enough experiences in failure. That's going to be the last theme, which leads me into conscientiousness. And again, it's a bias to me, but I think it's probably one of the most important things that we have to consider and pay attention to. If you want to read about this a little bit, I wrote an essay that was published on EMcrit a few weeks ago, and it's about the anti-fragile emergency physician. So conscientiousness is really two things. The obvious thing is that we need to work ethically. So what does that mean? Yes, we're not going to lie and stuff, but it means that we're going to seek help when it's appropriate for the patient, right? That even though that you say, I should have that skill, you have to judge, do I have that skill at this point to manage this patient? And don't let your ego get in the way. Seek help. Remember that we need to be patient-centered and recognize and be open in terms of your limits. And then this is the last one, and this is the most important one to me, is that you have to have work ethic, right? And work ethic's important. If I have a choice between 5 residents, I don't care if you were in the top 10 of U of T or wherever you went. I couldn't care less. What I care about is somebody that's going to have a strong work ethic because I know that they are going to seek these experiences. They're going to be self-starters. They're going to experience both success and failure, and they're going to do well. And ultimately, they need to be what I think is, that, and many people believe, is that to be successful, you have to have this thing called mental toughness, grit, and potentially be even anti-fragile. Mark Twain says good judgment is a result of experience, and experience is a result of bad judgment. Just another play on what Mike Tyson said. And this is the path of success, right? We all think that success during a residency is this trajectory where we have to be better each year, where we know really the trajectory to success is this. Ultimately, you get there, you're going to experience all kinds of bad things. And if these two people reached success, which one would you take? The person who never had a problem or the person who had all kinds of problems? I'll take this person any day over this person. And there's been a lot of stuff written about kids. I love this term. Rescue your kids from affluenza, right? Teach them grit. And anti-fragile is about embracing error. And error is important for the economy. Error is important for you as clinicians. And we need to embrace it and figure out how we integrate it into our practice. So let's get back. You got a 5-minute warning, but you're just doing around. You're seeing abdominal pain. Your heart rate is this, okay? It's 78. You look at the board now, and then this is what you see. Self-inflicted gunshot wound to face, no tube. This is your heart rate now, okay? It's gone up to 126. What's happened at 126? At 126, you're starting to lose fine motor control. We have to keep calm and carry on. That's the classic one. But the problem is sometimes I can't keep calm because I've got anxiety, right? And you do need to sort of, manage that. So gunshot wound to face, this is going to be a trauma team activation, but say you're in a place where you don't have trauma team. It should be, and this is a dilemma in most of our outlying places. Surgeons won't come to the emerge unless there's a CT done, right? What should be the default trauma team is that your surgeon comes in with your emerge doc, with your anesthetist, and whoever to help take care of that patient. So you have to balance, am I going to keep calm? Am I just going to not call anybody and take care of the airway? Or what's appropriate to do is say, wow, this has got the potential to be bad. I'm going to ask for help. Now, so you ask for help. You call your anesthetist and say, listen, gunshot wound. It's coming in. It's got 5 minutes. And he says, well, why are you calling me now? They're not even there yet. Call me when he gets there. Right? So what we need to do is know how to deal with buses or assholes. We do deal with this, and unfortunately, conflict avoidance can kill, right? This guy's saying, "Oh, just wait until they, come and I'll come down," and now you really need some help, and they're 10 minutes away, and that 10 minutes of hypoxia, and the patient's going to have a bad outcome. You need to know how to ask for help, and I have a script. I'm not soft on the phone. It's, hi, Tom, listen, we've got 5 minutes, there's a gunshot wound to face. This is a direct call to the staff anesthetist, not to the resident. They're going to be in room 12. Appreciate your help. Come on down, bring whatever equipment you have, but you've been in our department, you know what we have. I want you to help me manage this airway. I'm not saying, here's a case, blah, 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 and leaving an open-ended question. I've got a script. It's very firm. It's going to escalate if it gives me a reason not to come, but I don't really give an option. You have to be specific and say, I want help now. So this is your case, and this is a case that came in, we had, and this is gunshot wound to face. And what happens here, the classic one is that they've got a shotgun there, they've got it underneath their chin, and the length, based on the arm length, it usually happens to shorter people. To pull the trigger, that last part of pulling the trigger, they have to extend. Right? So as they pull the trigger, they extend, and instead of blowing off the brain, they blow off their face. And they end up presenting with an intact brain and a partially blown off face. So now your heart rate, when you see this patient, has gone from 127 to 147. You know something's happening. You see this patient. The energy's high in this room, and you're waiting for something to happen, and now what's happening? Now your heart rate's escalated to 179. What's happening when your heart rate's 179? It's very, very different than Scott doing a marathon, So Scott's still got fine motor control that he can actually text and do selfies, right? But if it's fear-based, if it's a fear-based tachycardia, completely different game. Different things happen. And really, when you think of it, the stakes are pretty high when they jump out of the back of a, these are PJs. They're special forces, Air Force. They're the guys who can, resuscitate you and do a crike with one arm and kill you with the other arm, But when we gather for this case, it's equally high stakes. Right? It's, when people, if you were to say to lay people, is there much difference in this environment? A lot of people would say no, equally high stakes. What do we do? How do we manage times of stress? This is called the Yerkes-Dodson curve, and it's pretty well known, but performance, you need a certain amount of arousal, right? When I'm giving a talk, I need to have my heart rate up to give a good talk. You need to have your heart rate up to perform well, but at some point, it becomes a critical point where your performance will decrease. If you take 100 people that are on a ship and it's sinking, they say that about 5 to 10 people will naturally come up and lead. And they're not doctors or special forces. They might be a janitor, they might be a teacher, they might be a lawyer, they might be, whoever it is. 5 to 10% will naturally lead, okay? About 20% of people will freeze and walk around like this, and walk into the water and die. The remainder, about 75%, will follow. If they happen to be next to one of those 5% that lead, they'll potentially live. If they're next to somebody that's one of the 20% that's walking around and walking to the water, they'll potentially die. So how can we take control of that group of 80, right? That many of us are. That we can improve our skills in times of stress. This is from that book on combat, and I'm going to break this down. And it really talks about your fear-related dysfunction associated with your heart rate. So when you're sitting here in this white zone and your heart rate's 78, you know, as you're sitting here watching this lecture, you're feeling pretty good. The yellow zone is 115. At around 115, 120, you start to lose fine motor control. But most of what we do, including intubation, doesn't require fine motor control, right? So you're still able to perform. This is the optimal combat-ready zone that the military talk about. This is where they want their people to be, you know, when they're jumping out of an airplane. They need a certain amount of energy that's going to increase their performance. But the decline starts at around 145. This is the gray zone. Many of us, essentially at 175, we're going to be down here. We're not doing so well, right? But these PJs, these special forces people, can expand that combat-ready zone to 175. So are there strategies that you can increase your abilities during times of stress? And beyond 175, quite literally, this is when you shit yourself. You know, your cognitive process, you've got tunnel vision, you freeze, and potentially lose bowel and bladder control. So let's get back to it. You know, your heart rate is 147. I can't keep calm. I have anxiety. How am I going to, you know, think during this time? And many of you probably heard this. Pat Croskerry talks a lot about really there's two systems of thinking. It's way more complex than that. But system one is what a lot of merge docs feel that they use, especially if they're experienced. It's rapid pattern recognition. It's the sick versus non-sick. You walk in, your gut says something bad's going on. We use what are called heuristics, which are shortcuts. What the inexperienced does for system one is say they go in, ACLS, somebody's dying, algorithm, okay. Next is epinephrine. Next is, you know, this. Next is that. Right? That's what the inexperienced do, and even the experienced sometimes draw on algorithms. System two is the, okay, this doesn't make sense. I've got to step back and say, you know, what the hell's going on here? So the novice uses it when a clinical clerk comes in and tells you about an ankle sprain, but they're giving you a review of systems related to their head and their chest, and they're doing tactile fremitus and all this stuff. Being inclusive. Or what we do is at experienced people, when system one fails, we have to step back and say, hey, is there anything else going on to consider? A lot of the other strategies that people do are, there's a lot of stuff now about algorithms, and checklists are big now. And there's a bunch of, airway checklists that are out there trying to draw on what they're doing in the air industry. And then various algorithms for managing the airway. These are the Canadian Airway Focus Group guidelines that were published in the Canadian Journal of Anesthesia in the past year. But I'm going to take you through an algorithm here for a second on this patient. So he comes in. Do you predict difficulty with intubation? Yes, right? You don't have to go through whatever lemon or map or whatever you do. Yes, you predict difficulty. See, the next question is you have to say, am I going to be able to oxygenate this patient? Right? And really you have two answers. You say, I think it's going to be successful, in which you're going to do a RSI with extra preparation, which I'll talk about that in a minute. Or this one, not predicted successful. And whenever an algorithm ends in the right lower quadrant of the screen and it says other options, see text, right? You know that there's no simple answer to managing that case. But this is one of those cases. And so in choosing between paralyzing this patient and not paralyzing this patient, again, what are we going to do? Are we going to play the odds, okay? Or are you gambling? And they're two different things. We play the odds all the time. And there's some people in this room who are very good at playing the odds. And that's sort of, you're playing cards, you're a poker player. There's skill, you're assessing, the person you're playing with. You know what hand you have, and you're making decisions. No question they're not certain decisions, but at least they're informed decisions. And it may turn out to be the wrong one, and you might lose that hand, but you got to play, right? In this situation, you can't walk away from this. As opposed to gambling, which is really saying, well, okay, I've got a choice between paralyzing them and I don't know what, but I'm going to do this because I think it's easier for me, right? Not necessarily best for the patient. So we want to avoid gambling and try to play the odds in this situation. What happened with this patient is that we do what I call is facilitated cooperation, where you're doing, Weingart would call it a delayed sequence intubation. So we're doing it for the purpose of, he does it for the purpose of oxygenation, but you ketamine, try to do DL, and if at the end the person's going to die, then you might as well do whatever you need to do, and that might include paralyzing the patient. This patient was actually intubated awake and successfully. But really, all these checklists are about this. It's simple, right? You got your plan A, right, which is usually, I think it should be good laryngoscopy and simple measures such as a bougie. If it's going to be video for you, fine, doesn't matter. Maybe your plan B is when this fails, but you can oxygenate the patient, you're going to pull out some sort of electronic device that helps you see around the corner, a video laryngoscope. And your plan C is always going to be a knife, but before you cut the knife, you might throw in a supraglottic device. There's this thing out there that I believe is called device confusion. It's something we didn't have when I went through, right? There was a laryngoscope, you had a straight blade and a curved blade, and that's all the choice that you had. Nowadays, there are all these devices, and there's something what I think is device confusion. But really, there's only two classes of devices. There's you have time devices. In other words, I'm unsuccessful in trying to intubate them, but I can oxygenate them. So I can now pull out something else that we think is going to be helpful in this situation, as opposed to there are no time devices, where I say, okay, I can't bag mass ventilate this patient. I've got to act now. I've got to throw in a supraglottic device before I go ahead and ultimately intubate that patient. So have time devices, have no time devices. But what's happening is that there's this big question now about when do we cut the neck? So, is it 90%? Is it 86%? Is it 81%? Is it 76%? At what point do we pull that trigger? We all know at the end of every algorithm it involves a knife of some sort or some sort of technique to gain access to the trachea. Where is it? This is a play on crit con that Weingart did. This is from the developer of Vortex, which has gotten a lot of press. But now the term is ESA, emergency surgical airway. And essentially saying there's a ready status, right? When the ready status is this, is that you might have your equipment out, and to us it means you have a bougie, you have a number 6 tube, and you have a number 10 blade. It might mean that it's now actually that in front of everybody you're palpating the neck, you're landmarking, in some situations you're actually marking the neck. And you're not doing that just for yourself, you're doing it to everybody in that room to say, I believe that this is a difficult airway, and everybody pay attention to this, and this is potentially the path that we might end up in this situation. But you don't want your plan A, your plan B, and your plan C to keep on doing this. And this still happens over and over again. We'll teach AIM, we do it all day, we do this moulages at the end of the day, we inflate the tongue, make it difficult, and what do? They do the same thing. They try to lift again, trying to get that better view and doing the same thing. A fixation bias, Einstein said insanity is doing the same thing over and over again, expecting different results. So when do you pull the trigger, okay? I get frustrated with books and articles that talk around what you want to know. Most of us say, okay, yeah, well, when do you think we should pull that trigger? When is the go time? I understand the ready, I understand the set. Weingart talks about the fact that in some patients you'll infiltrate the neck and do a vertical incision, right? And he says at the end of the day, if the patient wakes up and they've got a cut on, you might be able to explain that. I don't know how many cases he's done that, but it's a certain stage of readiness that he's telling the group, I'm very concerned about this patient, this is where we might end up. So pulling the trigger, I don't think there is a number, right? I don't think there's a 78, 81, or whatever it is. It's a sound. Okay? And that sound is this sound. It's the sound of ineffective bag mass ventilation. And what's the other sound in the background? Sats dropping. That's all you need, right? I don't need to look at this picture, right? You're walking in, you know the sound of ineffective bag mass ventilation, and the sats are falling. Yes, you can put it in an oral aid, do 2-person, but your brain should be, right now, somebody's delegated to go to the neck. If we avert that, that's fine. So it's a sound of bag mass ventilation, it's being effective, and it's a tone change. Whether it's 93 to 91 or 78 to 75, it doesn't matter. You're not going to pull that trigger. Your brain needs to be headed in that direction. And there's always somebody in the room whose job it is to yell out, 89, 88, 87, 86. In fact, when we get in there and we assign roles, I say, okay, somebody's going to do this, somebody's going to do that, and who's going to call the following sats out as this patient goes bad? But there seems to be plenty of volunteers. One of the problems is this, what I believe is, it's called omission bias. And omission bias happens with twice the frequency of commission bias. So what's the difference? Omission bias is saying that you're not going to, there's somebody that needs procedure X, and you're not going to do procedure X because you haven't done it before, and ultimately that patient dies. We're much more comfortable with that situation as opposed to us now doing procedure X and the patient dying, because everybody's going to say, well, really, why were you doing that? That somehow is related to that patient's outcome. So we have to be prepared to do something that we don't do very often. So let's get back to these cases here. And I'm going to go full circle as I talk about lessons from combat. So can we manage our own stress and physiology to improve patient care? But anti-fragile simulation, again, if you want to read it, you can read that essay I wrote. But again, another Mark Twain quote, do the thing you fear most, and death of fear is certain. Overlearning is critical. And what overlearning means is you don't want to reach just a level of adequate competence from an airway point of view, right? That's not the goal. You have to reach a level of skill mastery. So your goal is to get up here. Your performance over time, and the slope's going to be different for every person. But the higher you get up, the less likely you are, or the longer it takes for you to fall. But what happens is we will all fall. So if we as staff or whatever only do, we did all of our tubes during residency, and now we let everybody else do all of the tubes, how are we going to maintain those skills so when we need to do it, we're there and able to do that? Because the trajectory for everything that we do over time is decline. What is that slope? We don't know. But if you then go and overlearn again, it's quicker to achieve that. So this slope is much steeper than this slope. And now the slope of decay is more favorable. It takes more time before you lose that skill. So we have to be conscious of the fact of what's this interval that we need to be able to do that. In our department now, we've instituted a monthly cadaver access where staff are going to go. There's time for staff, time for medics, time for nursing. And they can go in on their own, and there's no, a lot of people don't feel like, practicing when their peers are around, but they can do it using real human tissue. So yes, we can. We can also do what I call a System 1 training. And System 1 training are fixed action patterns. So we have those, auditory cues that you just saw of bag mass valve, ineffective, and a falling sat. There's certain visual cues. I mean, there's olfactory cues. You walk into a room and a sick patient, you smell shit. I mean, that patient is sick, right? It's something that triggers I'm going to do something bad's going to happen. And sometimes people have time-based cues, right? So some programs or whatever, from an airway point of view, you've got 30 seconds, 60 seconds, or whatever it is. If you don't, you have to change behavior. But you do need to do something different. So I'm going to give you a task here. I need a volunteer. I'm going to volunteer you for a second. I want you to just quickly read out that number on the top. Just quickly read it out loud. 902-422-04. Okay, close your eyes. Okay, can you say that number?
902-422-416.
Okay, all right. Not bad, actually, pretty good. You're supposed to do worse. Okay, so now what I want you to do is I want you to close your eyes. Sort of read this number out.
519-645-7278.
Okay, close your eyes.
519-645-7278.
Okay. So what's happening in the brain is this is processing 10 numbers, right? And it's more difficult to process 10 numbers. Here he's either processing 3, right? Or he's processing actually 1. So what a fixed action pattern is rather than us trying to tell you, okay, in your brain, memorize this. Before you go to your exams, before you go to MULA, and this is one of our algorithms that we do in terms of our equipment. We try to say it's simple. There's essentially 2 A's, can't oxygenate and can oxygenate. But it's a bit more complicated in the brain. How do we deal with this patient when our brain has to draw upon this? It's a challenge. So what we want to do is do this. You see an epiglottis only view, and it triggers these actions. Okay? And that's sort of, it's mental rehearse. And that's what we need to do. When we're preparing to manage an airway, and we say, okay, what are you going to do to prepare to manage the airway? Well, I'm going to get an endotracheal tube, and I'm going to get a laryngoscope, and I'm going to get a suction. Do you need anything to help you do that? You know, at this point, it's all a fixed action pattern. You know what that is. But what you don't do is mentally rehearse for when you see this epiglottis only view. And it's the same thing. I'm doing the exact same actions in this situation. This is what we call as best look laryngoscopy. Instead of it really being 6 moves, it's 1. And that's sort of taking something, a visual cue, and if I were to say, if somebody come into our program, it's going to potentially save life, it's those 2 things. Recognize somebody who's not satting well, and you have to do something now, and it's those sounds that are going on in the room, and recognize when you see pink and you don't see a black hole with pearlies, what are your immediate actions going to be? So the other thing is checklist plus. So again, I don't need a checklist to say, you know, remember to draw up an induction agent or get your suction or whatever. Maybe we do. You know, maybe it's a good thing. But I think what we should do is add these cognitive biases here so we remember these are the common errors that happen. That should be part of your checklist. You know, this is my top 10 list. You know, we don't communicate. We walk in and we take care of it and everybody's in their own silos, acting as if they're calm, acting as if their heart rate is 80 when it's not. You know, assign roles. Preoxygenate appropriately with high flow nasal prongs. Care with assisted bag mask ventilation. Big pet peeve. Somebody's doing this top of the bed while the patient's breathing. As soon as you give them, you know, paralyze them, they're going to regurgitate all over you. You have to take care with little things like expect a poor view, mentally rehearse. Use best look laryngoscopy, which means doing your head lift. Don't fixate on intubation. Don't abandon oxygenation. Don't abandon oxygenating the patient to take control of the airway. Patient SATs are 70. They're not going to benefit from induction to paralytic. They're going to benefit from measures to try to oxygenate that patient. And there are other things that you can do. Adjust your induction agent to blood pressure, age, condition. Volume bolus, I'm a big believer. I start pressors before I start anything else peripherally in patients that I feel are high risk. I'm not a big believer in bolus pressor. Right? Our patients don't require a little bump as they do in the OR. Their blood pressure is down for a reason. So I'd rather, you know, get it going before we actually start. Manage your own anxiety. Appreciate these threatening biases. So these are the things that I think that we need to have triggers, mental triggers from. I'm going to close with a couple things that I got from my time with Scott Weingart, and is on his blog site. He had an interview with this fellow, but this is not Mike Gloria. Mike Gloria is now a medical student who was one of these PJs. He's a special forces critical care paramedic who's now in medical school. And this is a woman who did this TED Talk called by the name of Amy Cuddy. So how can we take control of our own physiology to improve patient outcomes? This is her study, and it's a fascinating study. They took a random group, I don't know how many there were, and essentially they did, so it was a group in this room, and you all had to spit to give a sample of spit, and then they analyzed that spit for testosterone and cortisol. And then one group had to, for 2 minutes, do a power pose. And they didn't have to do it in they didn't have to do it in public, so a Wonder Woman kind of thing, you know. They stand like this, right, or they're like this, and the other group had to sort of sit there and sort of, you know, be quiet and do this non-power pose. And then after 2 minutes, they tested cortisol level and testosterone. So, and again, the principle is that testosterone is sort of this endocrine measure of perhaps confidence, and the cortisol is a surrogate marker of stress. And in 2 minutes, marked decrease from increase in testosterone in the high power pose, in the lower power pose, marked decrease in testosterone. And from a cortisol point of view, the opposite occurred, so the cortisol level dropped in the high power group, and in the low power group, it increased. Again, surrogate marker that your confidence is going to increase and your stress might decrease. So again, what we're trying to do, what does that mean? What are you going to do? You're going to you're walking into a trauma and you're going to go like this. You can do it in private, but it does mean, that I got to go to the bathroom for a second. Look in the mirror and do it. But honestly, God, I do. It's important not to, when you're in a place and you got to take control and people need to listen to you, that you need to speak and be confident. And by, I think, doing that, what you are doing is, from a chemical point of view, making you focus and making you a better acute care decision maker. So I advise you to go and listen to this podcast by Weingart on this fellow by the name of Mike Gloria. And what he also talks about is this, which is focused attention. And focused attention is just it's the baseline, meditation. And Weingart says that before he goes in for a trauma, he does this, right? And he says, because I know I'm going to get in a fight with the trauma surgeon, right? And so before he goes in, he does this tactical breathing. And tactical breathing is, again, there are apps for it now, but all it is you're trying to think just about your breath. And it's 4 seconds in, 4 second hold, 4 second out, 4 second hold. And you do that cycle about 3 or 4 times. And if you're able to just focus on your breathing, again, hopefully what it allows you to do is now present yourself and be prepared for what you're about to meet. So what it's trying to do in this situation, what we're trying to do is capture that gray zone and avoid that gray zone being an expanded black zone, which it is for some. And there are methods that we can do, again, whether it's a fixed action pattern or System 1 training, or whether it's doing this minimum form of meditation or with tactical breathing, or again doing what we believe is important is anti-fragile simulation, right? So you have to go out and seek opportunities where you're exposed to a failure. So you need to learn from failure, be anti-fragile, overlearn, maintain the patience and your own heart rate, recognize key biases, and keep it simple for your brain. Final words here, because I can't speak about Airway without talking about this. We can't depend on technology for success. And many of us who've been around for a while get frustrated with all the CTs that are being done. I get frustrated with all the scopes that are out there. And I teach flexible bronchoscopy, not because I think it's necessarily going to be helpful, but because it's expected these days. This is the most important airway article, I think, of the century. And it was November 2013, and it was the FAA that came out with a report, and I have the report, saying that the greatest risk to aviation is autopilot, is automation. So that the pilots aren't experiencing how to land and how to take off planes. And that's a problem. They're not anti-fragile. And in this way, we can't, again, replace technology for core skills. There's a important one of the first articles about video laryngoscopy that came out, and the headline of that article was "Video laryngoscopy in a major center, far superior to direct laryngoscopy." And that's what it was. And no question, the numbers said that. But if you look at the numbers on that, do you know what the first attempt success rate was for direct laryngoscopy? It was 68%. 68%. If that was our flight team, we'd have to pull them. Right? If you had a 68% first attempt success rate, you've got a problem. Right? And why is that? It's because this group adopted and got really good with video laryngoscopy, and they thought they minimized the learning and training on direct laryngoscopy, thinking it's just about sticking a piece of steel blade in and lifting until you find some pearly whites in a black hole. And if you compare it to that, yes, video is going to be better. And if they just do it in plastic, you're going to say, yes, video is better. But what's the most common thing to rescue a failed video? Clearly, direct laryngoscopy. Right? So we have to maintain those skills. I actually, King Vision, I sold a patent that we had to King Vision, which is essentially the same device. So I'm a big believer in video laryngoscopy. I lost a hell of a lot of money on it. But I appreciate its value. But it's not a replacement for, it's about what's in the hand. It's not about, what's in the hand, it's about the hands that hold it. It's about the head that controls that hand. and it's about how you manage your own heart when you take care of patients. So that's it. This is my tracker. This is my family. Thank you. We've gone over. If I'm allowed to field a couple questions, I can, but it's up to you guys. Any questions anybody has? Come on.
I have a couple comments.
Oh, surprise.
First of all, it was a half marathon. George, you realize that an ace and a jack is not poker, right?
Okay.
It's blackjack.
I'm in school.
That's been my big concern, is that when we go into the trauma room, a resident these days is like, I'm getting the glide scope, I'm getting this, and it's automatically, I plan on failing this airway with the laryngoscope, so I need to have my 7 backup techniques ready. And the problem is learning how to properly intubate is not so fun. It's time consuming. It's something that only comes after years of experience. And I think people would like to have shortcuts so that they don't actually have to put in the time or effort that's required to learn the proper intubation techniques in the first place. And I think backup techniques are good, but there's no substitute for being competent in airway management with a laryngoscope.
Yeah, I couldn't agree more. And if anything, it's for that last reason, is that you have to be good at the thing that's going to rescue you, right? So it's a challenge. How do you remain competent at things that don't happen very often? And if you make laryngoscopy not happen very often, then you're going to lose those skills. And it's much more complicated than sticking a blade in and lifting. And same with video. Everybody thinks it's the same. I'll talk about that. And the next thing I'm going to talk about with the residents is the mechanics of airway management. And you have to individually problem solve. But what we get seduced by is the view. There's no question. And anybody that I review for annals, and if somebody publishes something saying that view's better with a video than direct, it's like, okay, if I walk 5 steps, I'm going to be 5 steps ahead of where I am now. Of course it is. It's a device that goes around and sees around the corner. It's going to get you a better view. The challenges are, and they're all device specific, is how you access and advance it. And there's all kinds of misconception about that we'll talk about. But I agree, you need to maintain that skill. And we talked a little bit about it last night. But I think the way to do that, and I think every medical school across the country almost has no reason to have access to clinical cadavers. Because you can get 5 years of experience in a day. You can feel those tracheal clicks that everybody says you should feel with a bougie, right? And you say, oh yeah, I can do that. You can do that mentally in person. But I agree.
Any other questions or comments?
You mentioned, thanks very much for an excellent presentation, Dr. Kovacs. You mentioned your staff do spend some time in the cadaver lab. The question is, how much do they spend sort of on a yearly basis, and is it mandated or based on personal?
So this is new, and I presented a version of this talk to our group, and I'm sort of this new official position as the director of the clinical cadaver program, which is another story for another day. But it's one of the staff said, okay, listen, we've got a resource, me as an airway guy and me as a clinical cadaver guy, why aren't we as staff getting access to it? And I said, you know what? Absolutely, you're right. So what we did, and this is going to cost us, our group, about $6,500 a year. Every 3rd Wednesday, there'll be a clinical cadaver which behaves as if you have a slightly cold, anesthetized patient. You saw the laryngoscopy there. No way you could distinguish that from real tissue. So it's going to be there every 3rd Wednesday for that entire day. The residents are going to have an hour and a half on their own for that time. The medics are, the nurses are for doing IOs and whatever, and the staff are. And we're going to do that 8 months a year. And we're not going to do it in the summer, we're not going to do it in March break kind of thing. And what it allows, the staff to go in, and there'll be somebody there as a facilitator to say, listen, we've got some new equipment, whatever, but, that you can do it, privately, and feel comfortable with it. Or bring as many people as you want, but everybody has their own time. And it's something that is very, very feasible. It's a technology that's inexpensive and accessible through most anatomy programs throughout the country, but not being done.
Excellent talk. Thank you so much for coming. I guess my other question would be, or my comment would be that it's interesting you bring up skills degradation as you become an attending, because I think it's something you don't talk about, and well, we don't talk about it. And it's assumed that the attending is going to rescue, you know, like somebody, now it's hamburger, right? And I have to rescue this. Well, and I haven't intubated anybody in perhaps 6 months. And that's true. There are staff that haven't intubated people in months, 3-4 months. Because I was one of them. I can tell you when I started, I mean, there were periods of 3-4 months where you wouldn't be intubating, right? And so I think a partial solution to that I found for myself, although it's not exactly, you know, the same scenario, is to actually go to the operating room.
Yeah.
And there are opportunities here, especially in London. There's one day a week where there's no residents in the OR. They're half day, and most anesthetists, even though it's not the same exact scenario, most would be quite willing to have you come in and do that. And I think that maybe even takes it to the next step to practice those techniques on the real patient, right? In a controlled setting, albeit.
The challenge to that is just the reality of it.
Right.
And we've done that, tried to do that before,
Right.
you know, and you know, for you to go out, try to figure it out, put aside the time, it's a one-off thing, there's not a routine, it's not part of the psyche that's there. You know, you'll do it a couple times. You won't necessarily have the devices that are up there. You know, you might have a long case and you might feel obliged to stay for that time. Right. And your experience has been, you you had 2 cases, right? Where you know, I can go in and I can create everything. I can create angioedema. You know, I call up the resident, come down and say, you'll see some video of this, and whoever's going to be in the mechanics thing, where you know, do a thoracotomy, open up, put a Foley catheter in the right main stem up in the trachea and start pulling blood through to manage a bloody airway and figure out which device works best. You know, compare, you know, surgical techniques, and you know, we're taking. I don't think the Mel curve should be on in anybody's department anymore. I mean, when you really compare the access difference and it's only through experimenting with this that you appreciate it. But it's something that takes a little bit of work. I think your time is better spent in get in touch with an anatomy, seeing how it's feasible. We keep one in our morgue, so it's in a blue thing, and you go down and take it out of the morgue, and you have to make sure we have a process to make sure we don't bring up the wrong one.
These are all fresh frozen, right?
No, it's not fresh. It's other technique I can tell you about. Yeah, they last for 4 to 6 weeks.